So good morning, everybody. I'm not going to be playing with urine, I promise. But I did want to talk to you about an effort that we started a few years ago at UCSF to really try to understand how all this technology can, in fact, improve healthcare, and how we might use the technology to do clinical trials in a cheaper, faster way. And so I'll just walk through the process of what we've done. So the Healthy Heart Study is a cardiovascular-focused, entirely electronic cohort that leverages the internet, mobile technology to collect real-time, real-life, dense measures and outcomes using surveys, apps, sensors, electronic health information, and biospecimens. That's a mouthful, and in short, we're trying to collect big data to predict, prevent, and treat heart disease. You heard earlier about the promise of big data in healthcare. And I think one of the problems with healthcare is we really don't have big data in healthcare. Genomics aside, medical records, on average, patients come to the doctor once or twice a year, and the medical records are generally a billing engine and not necessarily a data collection engine. So we set out to try to leverage technology to collect big data. And we really had four main goals in doing this Healthy Heart Study. The first was try to develop infrastructure and technology to do clinical trials and clinical research much faster, much cheaper, and in a much larger way. Our goal is to enroll 1 million people over the next 3 years to collect this kind of data. Most of you in the room understand the cost of doing clinical research these days. This is now data from 2011, so this is now old. But it costs between $15,000 and $45,000 per person in a clinical research study to get something done. So that's just incredible and not sustainable. This is a result of a lot of things, but one of the main problems is that you need a physical study center. I'm conducting a large multi-center trial that's been going on for about 4 years to try to prevent sudden cardiac death after a heart attack. And we've been doing the study, as I say, for 4 years. We've enrolled about 1,500 people of the 2,000 required, and it takes 90 study centers around the world to enroll these 2,000 patients. It's incredibly expensive and inefficient. It should be no surprise to anybody in this room that the adoption of technology is just exploding. Currently, right now, in 2014, 85% of Americans access the internet regularly, and in a few years, about 65 to 75% of Americans will access the internet using a mobile device. And people who have smartphones keep their smartphones within 3 feet 24 hours a day. So these devices have the potential to really become incredible monitoring tools. And when you take into account the sensor revolution that is just now starting to happen, the wealth of information that we can collect for research can be huge. The second thing we wanted to do was to collect data to do better disease prediction. Really try to get at the personalized pattern-based prediction that is the holy grail of medicine that we're quite far from. So if you look at these two people, how many of you would predict who had the higher risk of developing cardiovascular disease? I think most of our current understanding would say the guy on the right does. However, for those of you that are old enough in the room to know, the guy on the left was actually Jim Fixx, who started the running revolution in the 80s and dropped dead of a heart attack at age 50. The guy on the right was the Subway guy who subsequently lost a lot of weight, is pictured here on the right, and is still alive. And we don't currently take into account any of those things in our risk prediction. What we do instead is we take data from small populations and try to apply them to the individual. When I'm sitting in front of a patient in my office, trying to talk to him or her about their specific risk of heart disease, I refer back to studies of a few thousand people, and given a certain risk prediction, 30% of those people developed heart disease, and I say to this person with that characteristic, you have a 30% risk of having heart disease. In fact, he doesn't. It's sort of a weird way of applying population risk, but it is what we do, and it is the current state of the art. What we do is we add up a number of factors that were identified in that population. We look at their age, and we do this, go across this little table and say, you have a 4% risk of developing heart disease over the next 10 years. And that risk is assumed to be static. And we base treatment decisions based on that static risk at that moment in time. So we want to change that, and we're trying to collect data that's dense enough and repeated enough to be able to do that. The third thing we want to do, and have been doing, is to create a sandbox or playground for developing and testing and validating mobile health and sensor technology to improve health. We've heard a lot about all the great stuff that's being developed, and it is truly fantastic what we're able to do on small, cheap, scalable devices. But if we can't demonstrate how they're going to actually improve health or reduce costs of healthcare delivery, they're nothing more than a nice little piece of electronics. And so we wanted to create a way to do this in a very rapid and nimble way. This is just demonstrating the consumer approach that these technologies have taken. And it's wonderful from an engagement standpoint, but we really need to go to that next step of understanding how it's going to improve healthcare. And the poor Fitbit's been picked on a lot this morning. But this is data from our study. We have about 600 people who bought Fitbits, they went out and had the initiative to buy Fitbits in our study. We have about a year's worth of data on them. And this is exactly what happens. You see their steps don't actually increase over time, they decrease slowly over time. And then about 6 months, most people stop using it. And it doesn't really improve their health, this device in and of itself. And then lastly, we wanted to develop an infrastructure to play around with new disease management and delivery systems and strategies. You heard a lot about this in the last talk by Dr. Green. And we wanted to be able to collect and have enough connected people that we can very rapidly determine whether these kinds of new delivery and management strategies can reduce costs. A couple of examples that are ongoing that we're doing. So about 4 years ago, we developed at UCSF a very successful program to reduce heart failure admissions once they left the hospital. We were written up in all sorts of the best medical literature, like the New York Times, for example. The problem with this is that it takes an army to do this. In fact, there's a little, when we're on the inpatient service, we call it Saving Private Ryan, because it takes an army of people to make this work, and it's clearly not scalable and clearly does not reduce costs. We've started a project with Sensley, who I know is here at the meeting, to try to digitize this very successful program and make it scalable. And in the coming month, we'll be starting a randomized trial to really determine whether this type of approach is scalable and as effective as an in-person approach. Likewise, we're doing another study using remote blood pressure monitoring to determine whether that device and a smart algorithm for treatment of blood pressure is actually effective at controlling blood pressure, more effective than what's traditionally done. So the strategy we've taken is that of non-traditional sources of recruitment. We don't have study centers. The only study center is at UCSF, where we have our own patient cohort for validation in-person studies. But we have totally decentralized enrollment and management. We do data collection through electronic virtual visits, sensor integration. We've deployed and developed several mobile apps to do measurements, and we integrate with people's personal health record and some EMRs. We do biospecimen collection. We have a novel way to do outcomes ascertainment, which is critical in a rigorous epidemiologic study like we've tried to produce. And we've taken new approaches to the consenting and IRB approaches. One of the novel ways we have of enrolling patients in this study is through a partnership with the American Heart Association, and in the coming months we'll leverage their reach to pull people into the study. Another interesting aspect that we're releasing in 2 weeks at the American Heart Association meeting, in fact, is to enable practitioners anywhere in the country or anywhere in the world to enroll their patients as participants in the study. In a very simple way, they can create their own landing page that's personalized for their patients to see that their doctor wants them to enroll in this study. And in return, we feed data back to the physician about their patients and their patient cohort so that they can do QI experiments, et cetera, within the practice. We're very curious to see how this works, but we're excited about it. We take consenting and privacy extremely serious. This is a UCSF IRB sanctioned study. We have an NIH certificate of confidentiality, which means the data can't be subpoenaed. We don't sell it or give it to anybody. It's all completely HIPAA compliant. And we've developed a novel way of consenting patients that doesn't require repeating all of the legalese that most ethics and IRB boards require. Instead, our IRB has been very forward-thinking and allowed us to do very simple, plain language consenting with reference to the legalese in other documents. In fact, it's more streamlined than most end-user license agreements that you sign up for when you use any software. We've integrated with a variety of sensors and continue to integrate with more sensors, some that are released, some that are pre-released that we're testing and validating within the study. Currently, we measure activity, sleep, weight, blood pressure, pulse oximetry, glucose levels, EKG, and I'll just run through some of these examples. We've also created a hub where our participants can use the study to collect all of this information in one place, including data about their medications, family history, and their personal medical record as well. You saw this earlier on Andrea's little trailer. This is a mobile EKG. I'm a cardiologist. This is one of the key measures we do in doing clinical research. And one of the difficulties in not having a study center, a physical building, is not being able to do some of these tests. There's a smartphone case made by AliveCor that we gave out to participants in the study. You just hold the electrodes. This is my EKG from a few weeks ago. And it records the EKG in a really nice, useful, high-quality way that just streams back to our study for analysis. And we can prompt people contextually or temporally to obtain that data. It's a little patch, a little disposable patch, that records a continuous EKG for 7 days. It records activity, breathing rate, there it is, posture, temperature, and all this just streams through your smartphone back to the study. We're doing a study with this looking at both heart failure prediction as well as atrial fibrillation prediction. And as I mentioned, we're on the cusp of this really remarkable revolution of sensors. And as these become smaller and cheaper and more scalable and more wearable, we will gain bigger and bigger insights. We've also developed a number of apps and deployed several apps within the study to measure things like activity, behavior, social interactions, environmental exposure, locations, etc. We also have developed a couple of apps that are somewhat unique to the study. We have an app that detects when people have been hospitalized, so that's a primary outcome in any epidemiologic study, and we can get more information about why they were hospitalized. This is an app we developed. As a cardiologist, the 6-minute walk test is this very well-studied, great test that measures cardiac fitness. It's a predictor of heart failure and heart failure exacerbations. It's a predictor of coronary disease, and it requires a nurse or somebody to physically administer it within a course in the clinic. So we developed an app that sort of just does that and measures it. We just finished the validation study of this that compares the app, somebody using this at home, to a nurse administered in clinic, and it performs quite well with a very high correlation. So now we can take, again, one of these tests that's traditionally done in a study center, have people do it at home, not one every 6 months, but daily or weekly, to follow their heart failure or their coronary disease in a measurable way. We've been working with colleagues at Purdue who have developed some novel image learning algorithms to do a technology-assisted food diary that uses a simple camera on your smartphone, feeds the information back to the server, and through learning algorithms identifies the food and quantifies it and databases it off of the National Nutritional Database. So we get quantifiable data on people's diet. I mentioned outcomes, and again, in any study where we're trying to determine health, we need to know disease progression and outcomes. So we spent a lot of time trying to approach this from a rigorous epidemiologic standpoint. We have an app, as I mentioned, that detects hospitalization. We integrate with several medical records. We can integrate with any Epic installation. The problem is not one of technology, it's one of administrative hurdles at a particular institution. And I'll show you in just a little bit, we've decided to go around that, and in about 3 weeks we'll be releasing the ability to allow people to connect their personal health record, their patient portal data, to the study in one simple step. This is our app that detects hospitalization. If they click yes, then they get delivered more questions about why they're there. This isn't delivered when they're in the hospital. It's delivered an hour after they leave the hospital. This is the very simple portal where somebody can go in, and this works with any of 300, right now 300 large patient portals from around the country, where people can just give us their credentials in a secure way, and we ping the portals daily to pull data in regularly. The other fascinating thing about this study is that when you have the democratization of data, so all of these patients are giving us data, all these participants are giving us data, and it's all living in a virtual world, it brings up the possibility that the participants themselves can begin to do research. And so we wrote a grant to the PCORI, the Patient-Centered Outcomes Research Institute, to create this patient-powered research network within the Healthy Heart. And we have several partner organizations that are patient advocacy groups. And again, the idea is that if you're a member of the study, one day you'll be able to pose a question, design an experiment, potentially get funding if needed, recruit participants, analyze the data, etc. And it's really kind of a wild thing to think about and very different than how we've ever thought about doing research in the past. And in fact, just last Thursday and Friday, we had a meeting in San Francisco where we only had room for 150 participants. We invited people from the study to come to San Francisco to have the first ever patient-powered research summit, to sort of walk through what this process might look like and actually come up with collaborations amongst patients and participants who would design questions and research studies within Healthy Heart. And it was a absolutely amazing experience to sort of have these 150 patients in a room designing experiments. It was great. So progress to date, we began working on this about 2 years ago. We began enrolling patients in April of 2013, not because we were ready, we were still developing the technology, but we were fortunate enough to get some early press. The Wall Street Journal caught wind of what we were doing and wrote a story, and we said, well, we have to be able to enroll patients if it's coming out. So we quickly put something together, version 1, started enrolling in April 2013, and continued to develop the technology, and really started in earnest about a year ago. We currently have 10,000 participants in the study. They're from all over the world. I think we have 32 countries represented in the study. However, as you might expect, most are in the United States. The geographic distribution within the United States largely follows population density, with the exception of California, which is a little overrepresented based on its population. Our demographics, again, are sort of ideal for this study, not what we expected, but we have about 70% of our participants over the age of 50. We were concerned we might have a bunch of 18, 20-year-old worried well, obsessive, compulsive people. But in fact, that is not what we have, which is great. Evenly split between men and women. And the disease prevalence kind of follows what you would expect in the general population. So 45% have high cholesterol, 35% have hypertension, et cetera. So it is not a bunch of worried well. It's a nice mix of healthy individuals as well as people with some degree of heart disease. So what have we been using this for? Well, we've been using it for very rapid cohort selection. And I'll just give you one anecdote. About 4 weeks ago, one of my faculty said, you know, I have this idea to develop a novel way to do an echo to measure atrial function. I won't go into details of what that is, but I need 100 normal people so I can figure out what the normal values would be. So we went into our Healthy Heart study. We can, within about 30 seconds, identify people without any heart disease who live within 60 miles of UCSF. We sent an email invitation out, and within 24 hours, we had all 100 slots booked for the next 3 months. So it's very useful for doing very rapid cohort selection. We can deliver interventions immediately. We just did a small intervention trial to try to get people to use their Fitbit more. And that took about 2 weeks to enroll patients and deliver the intervention. We can follow cohorts over a very long period of time with very minimal burden and much lower cost. We've begun a study with the Framingham Heart Study, sort of the quintessential cohort study, where they've approached us to do their data collection on their cohort going forward using a lot of this technology. The Childhood Cancer Survivors Network is another example. There's a very large cohort of about 25,000 adults who survived childhood cancer, and they have a significantly higher risk of developing heart disease because of the cancer treatment. And so we'll be following those 25,000 people using this technology. We can obtain dense measures that typically were done once or twice a year or every 2 years. We can now do daily or continuously in some manner. Anybody can join. You don't need to have heart disease. It's a really simple thing to do. Doesn't take very long. And I guess we'll have questions in the panel. We won't have questions. We're out of time, Daniel tells me. So I'm done. I'm being given the hook.